Good morning. I'm Susanna Massardis, CEO for the Community Liver Alliance, and I welcome you to our first Pediatric Liver Conference. Today's conference brings to you information by subject matter experts from across our nation. We are delighted to provide this important education and an opportunity for you to network and meet others that share your journey. We support our mission through our Liver Hero initiatives. The Community Liver Alliance invests in research and innovation to find new therapies and hopefully cures for the many liver diseases. We also provide small stipends through our patient assistance program. And in my opinion, the most important pillar is our commitment to our young liver patients, their families and caregivers through our support of the Children's Hospital of Pittsburgh's Camp Chiope Youth Transplant Camp and this new pediatric conference. We are dedicated to providing meaningful education to the liver community, and our hope is that you find this conference valuable. Your opinion is important to us, and we encourage you to take the patient survey and the evaluation associated with this program to let us know how we can best serve you. You're an important part of the CLA family, and we count you among our valued allies in the fight against liver diseases. We thank you again for being with us here today. We thank our expert presenters, our planning committee and sponsors, Alexion and FedEx, who all made this day possible. And on behalf of the Community Liver Alliance Board of Directors and staff, I wish you a wonderful day, holiday season, and all the best in the new year. It is now my pleasure to introduce Dr. George Madriagos. George is the Division Chief of Pediatric Transplantation at UPMC Children's Hospital of Pittsburgh, the Hillman Center for Pediatric Transplantation, and the Thomas E. Starzl Transplant Institute. He is a professor at the University of Pittsburgh in the Department of Surgery, Anesthesiology, and Critical Care Medicine, and holds the Jamie Lee Curtis Chair in Pediatric Transplantation Surgery. Dr. Madriagos has been involved in the academic field of transplantation surgery for more than 25 years. And recently, Dr. Madriagos and colleagues founded the Starzl Network for Excellence in Pediatric Transplantation, a consortium bringing innovation and tech partners together with patients, families, and transplant centers to transform outcomes in children undergoing transplantation. Dr. Madriagos is also a part of the Community Liver Alliance Board of Directors and a great asset to the wider liver community. Please join me in welcoming our program moderator for today's conference, Dr. Madriagos.
Thank you so much, Susanna, for that kind introduction, and welcome to all of our attendees and registrants. I hear we have a great number of registrants and from all over the country, and that's very exciting to be able to participate as the Community Liver Alliance in its impact throughout the United States. So we welcome all of you. We welcome our patients and families who are listening in, and I'm very proud to moderate this expert panel that you'll be hearing from today. Just a couple of housekeeping items. We really welcome questions, and we hope to have a lot of discussion between the audience and the presenters. So please, if you do have questions, write them in the chat box. And we'll take questions after every other speaker, I believe. Also, there's going to be a survey that's available currently in the chat box that we ask everyone to take. We really strive to improve and to get your feedback and to transform that into an improved experience in the future. And we'll also be sending this out to the participants after the conference. Now, I'm very honored to introduce and get this conference started with Dr. Rick Superina, who's the Division Chief of Pediatric Transplant Surgical Director and Director of the Intestinal Rehab Program, the Surgical Director of the Liver Transplant Program at the Lurie Children's Hospital of Chicago, and Professor of Surgery at Northwestern University Feinberg School of Medicine. Dr. Superina is involved in cutting-edge research and has received numerous honors and is well known throughout the world for his contributions to the field of transplantation. He has a specific focus and interest in portal hypertension, congenital portal systemic shunts, tumors of the liver, and biliary atresia. And we are truly honored to have his expertise with us today. Rick is a wonderful colleague and friend, and I think you'll enjoy very much his presentation on both pre and post aspects of pediatric transplant care. A great way to get this morning started. Thank you, Rick, and look forward to your talk.
Thank you, George. Can you guys hear me okay?
Yes.
Okay. can you, the next slide, it's my no disclosure slide, but in fact, I have a couple of disclosures. I'm at an airport in Brazil, and you might hear the announcements of flights arriving and leaving, so I apologize. There's a few technical problems, which my earpods don't work and I have no volume control, so hopefully it'll all work out. It's easier than doing a transplant, so we should be able to pull it off. Next slide, please. So the pre-transplant journey starts with the diagnosis. And for parents, it's a very different experience depending on what the diagnosis of the child is, when you found out that your child needs a liver transplant, and how long can you expect your child to remain stable on a waiting list. These are all very different factors that affect the mentality of the parents as they go forward. There is a lot of stuff now on the internet, on sites like the one we're on today, where parents are able to share information, and you didn't have to learn about your stuff about the green baby boom from the journals that were available at the checkout counter in the past. Next slide, please. The pre-transplant expectations are somewhat dependent on the acuity of the illness of the child. There's a scoring system that was devised, quite a few years ago, the PELD score, which many of you may be familiar with, which is based on the acuity of the illness in patients with biliary atresia. But it has many limitations. And depending on the illness of the child, you may have a low PELD score or a high PELD score, or you can have what's called a status 1A, which is the highest acuity, or a status 1B, which is a class of acuity reserved particularly for children who have chronic liver disease with a sort of a sudden decompensation. I think it is pretty common understanding among all of us who deal with pediatric liver disease that these exception scores do not always accurately reflect the mortality of the child within the first 7 days or the first 3 months, which is what the scoring system was devised to do. So most of the children nowadays are actually transplanted with exception scores. And it's the job of a National Review Committee to look at these exception scores as appeals by program who are trying to get more points for their patients. And the bottom line is that there just aren't enough livers to go around and meet the demands of these sick children. The PELD score does not, even though many patients are transplanted with exception scores, all patients with liver tumors and metabolic conditions are transplanted with exception scores because these patients do not commonly have liver disease. They have urgent indications for transplant based on other things. So you can see on the left, there's a baby who's kind of waiting at home. He's in a clinic, and there's a baby in the ICU. So the expectations and the anxiety level for the parents of these children can be quite different. Next slide, please. So the transplant evaluation is really where the rubber meets the road. It's when the team has somehow decided that it's time to evaluate the child formally for a transplant. And this can be the day before a child is listed in the case of acute fulminant disease, or it can be months before the child really needs to be transplanted badly if a kid has something like a chronic liver disease such as biliary atresia, where the discussions may have taken place shortly after the Kasai operation. So the evaluation is the opportunity for the parents to meet everybody on the team. The hepatologists usually know the patient already, but the family gets to meet the coordinators who will be incredibly important in the future of the relationship between the team and the child and the parents. Pharmacists and of course social workers, incredibly important in trying to sort out the many different needs that these families have. The financial specialists, which are unfortunately a necessary thing these days with all of the myriad complications with regarding financial problems. And finally, you get to meet the surgeons. Now, the surgeons are not always familiar with the family because they may have been introduced to the family pretty late in the process. So it's very important that the family gets to have all of their questions answered. Next little animation, please. So ask questions. That is the message that I would have for any family who's going to be going through a transplant evaluation. It doesn't matter how small the point is or how many times you may have asked a question. It's pretty well known that people only retain about 15 to 20% of what they're told at any one given time, and that about a week or two later, they've forgotten much of what they've been told. So we encourage people to keep coming back to us with more questions through email, through my chart and other uh, media, because the concepts that we talk about are very complicated. It's what you expect at the time of the transplant. What are the complications that are going to be happening after the transplant? And very importantly, there's the whole discussion about living donor. You know, we introduce it in a way that doesn't sound like we're obligating the family that they have to have a living donor, but we try and encourage them by telling them about the positive aspects of living donor donation. Next slide, please. So this is the hardest time for the parents, is when they're listed. The stress level must be incredibly high. I think they can't possibly conceive of anything that's really more stressful. Next bullet point, please. I think there are limits on lifestyle, depending on, next slide, please, whether you're in the ICU, but even if you're waiting at home, it's really hard to go on vacation. It's really hard to do, to have a normal life. And I think one of the interesting things that parents express to me is they have guilt about waiting for a donor, because as much as they want their child transplanted, unless they have a living donor, they know that someone is going to have to die in order for their child to get a liver. And I think some parents, not all, are racked with this kind of guilt about wanting to have something happen quickly for the child, but realizing that something bad has to happen to some other child. And of course, after the transplant or even before the transplant, parents want to express their gratitude to the donor family. The time for preparation for all this can be very contracted in the case of a sick baby or someone who comes in with chronic liver disease, or it can be a long time if someone has a stable metabolic condition. So that the time frame that this process goes through can be very, very different among families. Next slide, please. Okay, so the problem is, of course, organ supply. There's a shortage of donors. There's a sizing compatibility because most of the kids who need a transplant are infants or young children, whereas most of the donors are generally adults. Next slide, please. My little yellow baby friend. So here is a pie chart, which I like. Pie charts are very easy to understand, of a age distribution of recipients that done at Lurie Children's Hospital in the last 10 years. And you can see the majority of them are in the blue or the red slices, which is almost 60% of our patients are kids below the age of 5. Now, if you look on the chart at the right, you can see that the peak number of donors is in the ages 15 to 34. So when I first started doing liver transplants, we had a very, very high rate of mortality on the waiting list because you were always waiting for a donor that never came. Somewhere in the late 80s, early 90s, we started doing reduced size transplants and split transplants, which I'll talk about in a few minutes. And that was a huge improvement in our ability to meet the needs of the sick babies on the list. Next slide. So the technical variant transplants, I'm not going to show a lot of OR pictures, but this one is kind of, I think, a necessary thing. When we get a liver from an older donor, we have to cut it down the middle or sort of off to the side to match the size of the baby. And the great thing about these technical variant transplants in this age when donors are in short supply is that you can actually get 2 patients transplanted with 1 liver. Next, and you can see here a very happy picture of 2 of our children who were transplanted with a single liver. Now, this doesn't happen very often because it takes a tremendous effort on the part of a team to do 2 transplants at once, but it happens on occasion. But the great thing about it is that the part of the liver that we don't use goes to an adult who's on the transplant waiting list. And so the more technical variant transplants that are done in this country, the better the situation will be for people who are waiting on the list, who are obviously very desperate to get a liver. Next slide, please. If you look at the frequency of split liver transplants between the 20 years between 1991 and 2010, you can see that there very few were done in the 90s and early part of the 21st century. In blue is when we started doing split liver transplants around the year 2000. And you can see that even though this slide is 10 years old, it's current in the sense that about 50% of our transplants now are done with organs that are obtained from adults who are then split into two sections, one for a baby and one for an older child or an adult. Unfortunately, this practice has not really taken off as well as we might have wanted. The number of split liver transplants in this country, next slide please, you can see has remained somewhat static. The great majority of children in this country are still transplanted with whole livers. And even though there's been a modest increase as exemplified by the brown line, we are still at the 20% mark. And there's no obligation to split livers. It's really completely on the center itself, whether they want to engage in this kind of practice. And the more people who engage in this kind of practice, the better it will be. Next slide, please. One of the interesting things about living donors is that we all, the first living donor transplant happened in Australia many years ago. In this country, it happened in the University of Chicago in the 90s. And it's become a basically staple of most pediatric liver transplant centers to offer this service, where a child, parents usually, or a relative are the donors that will usually donate about 20% of their liver mass to the child. Now, what's interesting, and this is data that is very, very recent, you can see that there's kind of a drop-off in the frequency of related living donors. I can't explain that. But what's remarkable is to see the uptick in the green line, which represents non-directed altruistic donors. So a lot of people are stepping forward and saying, I want to donate a part of my liver to a child or to an adult, but often it's a child. And this has become an important source of organs, particularly for children. And there are a lot of ethical discussions about how we allocate this resource, because in a non-directed donation, do we follow the list, or do we make up our own minds about who that patient might be? There are no allocation rules at the moment, but it's something that I think we all are very interested in seeing how this evolves. Next slide, please. The transplant phase, of course, is where the parents sit in a waiting room or somewhere and they pray or keep their fingers crossed and wait for the surgeon to come out and tell them how things have gone. What influences the length of the surgery is, has there been any previous surgery? What's the size of the child? What kind of graft are we using? Next slide, please. The postoperative phase is really characterized by a variable length of days in the ICU. You can expect your baby to be on a ventilator. You can expect imaging that happens almost on a daily basis. The first post-op day is the day that I think everyone wants to see that post-op day ultrasound. On the right, you can see a nice hepatic artery signal, a nice portal vein signal. Unfortunately, we prepare our families for returns to the OR. It's not always a bad thing. Rounds can be somewhat confusing for parents because now we have family-centered rounds where the parents are really an active participant in the rounds. And we have to be careful when we discuss things, and there might be some disagreement about some point of care where the families don't perceive this as the team actually strongly disagreeing with each other. Some families object to this. So now we have actually taken to sort of have the real rounds sort of in private, and then when we have a consensus, engage the family to tell them what we think the right thing to do would be. But it still can be confusing for families because there are so many caregivers and they hear so many different things from so many different people. Next slide, please. So the roller coaster analogy or metaphor has been used many times to talk about what it's like to be in the ICU with your child who just had a liver transplant. You have a euphoria of having finally received the liver, but every day seems to have its ups and downs. Will the liver function properly? What's the risk of bleeding? One of the focuses of our Starzl network right now is on the anticoagulation practices of our centers. Almost every child is on a blood thinner of some kind, and those blood thinners are used extensively to keep clots from forming in the arteries and portal veins to the liver. And as a consequence, there's an increased amount of bleeding, which worries parents a great deal. Sorry about that. That's the announcement. Anyways, about 30% of all patients have to return to the operating room within the transplant admission. Next slide, please. Fortunately, the liver has an immunologically privileged position among the organ hierarchies. The incidence of rejection is anywhere between 15 and 20% in that first year. Sorry about that. But the good news is that rejection is not usually a serious problem within the first year. It can be easily reversed. Next slide, please. The good news is that patient survival is great no matter what your age group. You can see here a 5-year survival curve is in the order of 90% for all children, whether or not they're less than 1 year old or whether they're teenagers. Next slide, please. There seems to be a small survival advantage for living donors in comparison to deceased donors. Even though living donors can be technically challenging for the families, for the team, they do seem to have a better overall result. Next slide, please. So the long-term survival is good. I want to just show a couple. Here's my famous yellow baby picture, and I'm going to show you the kid 20 years later. So this was at the Toronto Zoo on the 20th anniversary of the Toronto transplant program that I started a long time ago. And Vicky Ng, who's there right now, decided to have a party, and she invited all my old patients. And so this kid was like, "So you're the guy who cut my liver open?" I'm like, but you know, it's so gratifying to see these children. And I think as parents, you have to understand that even though you've gone through this incredibly intense experience in your child's life at an early stage, these kids can have a wonderful, happy life. Next slide, please. This baby was transplanted on Mother's Day, 1987. It was one of my first liver transplants. He had biliary atresia. And next slide, I met him at the zoo, and I thought that he was his father. I saw this guy coming towards me with sunglasses, and I said, "Oh, Mr. Raposa." And Mr. Raposa was a little old guy next to him, and the boy was actually got married a few months later. And so that was an incredibly gratifying experience too. So I think as parents, next slide, please, you have to understand that no matter what you go through, the transplant outcomes are excellent and your children have a wonderful life ahead of them in most cases. I always wonder what babies who have their transplants figure out later on in life. And this was a drawing that was done by a girl when she was about 11 years old who had been transplanted as a baby for biliary atresia. So, you know, it's always wonderful to understand, trying to understand what these kids think. So she drew this picture. She's kind of the circle girl at the bottom, and she's got a liver coming out of her head. So the liver is anatomically really good, but of course it's coming out of her head, which may indicate the importance to which she gives this organ. But what's really cool is that I am above her with protective arms around her. And I was incredibly moved by this little girl giving me this picture. It's in my office right now. And her perception of her journey through the transplant. And I think it's going to be very important in the future, now that children are surviving, to understand how they survive and what their long-term problems are. As a last message, I want you to choose your liver transplant center wisely if you have a choice. Not all centers are equal. I'll leave it at that. Anyways, that's it. Thank you for listening, and I look forward to the rest of the talks.
Thank you so much, Dr. Superina, for that fabulous overview. We'll look forward to some questions after our next speaker, and just encourage our listeners to put their questions into the chat box, and we'll get to those right after our next presentation. Now it's my privilege to introduce Dr. Alicia Mavis from Duke Health. She's a pediatric gastroenterologist and hepatologist who also works with intestine patients as well as her liver patients at Duke. Her goal is to do everything possible to help the child and the family really understand their liver disease and really participate in their care throughout this challenging process. So her task for this morning is to address our group on the top 5 liver diseases that affect children and how that impacts you. Dr. Mavis, thank you so much for joining us today, and we look forward to your presentation.
Thank you, Dr. Mazariegos. So thank you for having me. I would just like to say I have the daunting task of getting through the top 5 liver diseases in pediatrics in under 20 minutes. So I will talk fast and we'll just hit the highlights. Next slide, please. I have no disclosures. Next. We're going to go over kind of the most common pediatric liver diseases: biliary atresia, Alagille, alpha-1 antitrypsin deficiency, autoimmune hepatitis, and non-alcoholic fatty liver disease. Next. So we're going to start with biliary atresia. You've heard Dr. Superina kind of talk about it. We're going to go through the details of it. Next slide. Biliary atresia is a rare progressive disease that affects the bile ducts, both intra and extrahepatic, that results in scarring or fibrosis and blocking or obliteration of the bile ducts. It usually presents in the first 3 months of life. It is occurs in about 1 to 8 to 18,000 live births, some would say around 1 in 10,000, but it is the leading cause for liver transplant in pediatrics, as you heard Dr. Superina mention. Next slide. We don't fully understand the etiology or pathogenesis at this time. There's a lot of studies going on. There's been many proposed etiologies, as you can see there, and a lot of research is currently underway trying to identify the exact etiology underlying biliary atresia. Next slide. So what does it look like? Most of these kids are very healthy at birth, and they're healthy until they aren't, is what we always say on the medical side. So symptoms usually develop around 2 to 6 weeks of age, and that's when you see the jaundice, or your kid is looking yellow. You can have the white stools or acholic stools. They may start having poor growth. You may notice some itching, and as it progresses, you'll develop portal hypertension and a large liver and a large spleen. And these are just some of the symptoms, but usually at birth, these kids look pretty healthy. Next slide. Liver biopsy is one of our go-to things for biliary atresia diagnosis. It's got a 90 to 95% diagnostic accuracy. You can see what a liver biopsy looks like under the microscope. A lot of times they have normal liver architecture, but some bile duct proliferation with some bile plugs. Next slide. This is a cholangiogram. So when the liver biopsy is concerning for biliary atresia, we recommend a cholangiogram. Usually it's an interop cholangiogram where they shoot some dye and try and see where all the bile ducts are. And this is kind of a picture of that. I won't go through the details of it, but this just lets you know what they're doing. Next slide. If the cholangiogram is positive for biliary atresia, meaning there's a blockage of ducts, then you do something called a Kasai portoenterostomy. This is a surgical procedure that Dr. Superina or Dr. Mazariegos would do, and it's to restore the bile flow and prevent the progression of liver injury and development of cirrhosis. It's best if it's performed before 3 months of age. So this is where early diagnosis is critical, and this is why many of our kids are transplanted so young. Next slide. So 75 to 90% of kids that are 10-year free transplant survival have their jaundice cleared by 3 months of post-Kasai procedure. And 20% will be 3-year transplant-free survival if their jaundice persists past 3 months of age. So really the big thing is liver transplant is what happens if the jaundice persists. And more than 50 or about 40 to 50% of kids will be transplanted before the age of 2. Next slide, please. So that was kind of a quick thing through biliary atresia. We're going to run through Alagille now. Alagille syndrome is an autosomal dominant multisystem disorder, which is defines from abnormal signaling in the liver, meaning the liver disease is caused by certain mutations and different genes, usually the jagged one or the notch 2. It happens in about 1 in 30,000 to 1 in 50,000 live births. So not very common, but we do see this. And usually liver disease does not develop outside of early childhood. So if your child makes through to adult without developing liver disease, even though they have Alagille, then they usually will not develop liver disease. Next slide. There's a lot of clinical manifestations for Alagille syndrome. You can see here they can have the yellow or jaundice. They can have itching. They can have little xanthomas, which are collections of lipids. Poor growth. It can affect their kidneys, their development, and their eyes, or even their vessels. So there's a lot of things that come up with Alagille syndrome. Next slide. Usually it is a genetic diagnosis or molecular diagnosis, but this is one that we can diagnose clinically. So if we have a biopsy that is missing some bile ducts, and then you can see here 3 of the 5 major clinical features: cholestasis, that's the jaundice, eye findings or characteristic facial features or cardiac defects or the skeletal anomalies like a butterfly vertebrae, then this one may be actually diagnosed clinically even if the genetics do not match it, although we are doing more research and finding more of the genetic mutations. Next slide. For Alagille syndrome, the most important thing we do is symptomatic management. The biggest hardest thing for us to treat is actually the itching or the pruritus. We don't really have great treatments up until now. There's now the ileal bile acid transport inhibitors. It's a whole new class of drugs that has just been approved this summer and fall. And so that is what we're using right now to treat the itching and having improved outcomes. They can get bad fat-soluble vitamin deficiency. So we do a lot of vitamin supplements and we're monitoring their growth. You can still see there that 1/4 of them do go on to require liver transplant, and 1-year patient survival is about 80%. Next slide, please. So alpha-1 antitrypsin is another disease that we see and take care of. Next slide. This is another genetic disorder that results in reduced levels of alpha-1 antitrypsin. So alpha-1 antitrypsin is a protein that's made in the liver and excreted into the blood, and it is to protect the lungs from a certain enzyme that breaks down the lungs. It occurs in about 1 in 1,500 to 2,500 people. It's many different variants on the SERPINA1 gene, and this is where we say what is their pi typing or alpha-1 antitrypsin typing. Could be MM is the most common, and that's the one where you don't have any disease. But then there's a whole variation of the whole alphabet of different things where the worst disease is if you have a typing of ZZ. Next slide, please. So this one is caused by excessive amounts of alpha antitrypsin trapped in the liver cells of hepatocytes, which can cause ongoing and progressive inflammation or injury to the liver. So about 10% of infants born with this have severe disease and actually may have end-stage liver disease or cirrhosis and require a transplant early on in life. So another reason why a baby would maybe need a transplant. Next slide. Again, here's multiple clinical manifestations. As you're starting to see, many of these are very similar, where they have the poor growth. This group can also have the white stools or the jaundice, the large spleen, large liver, and the portal hypertension. So all of these are very similar in that they're all signs of worsening liver dysfunction. Next slide. So we normally do a blood test to determine the alpha-1 antitrypsin phenotype like we were talking about to see if it's MM or something else, but it can also be diagnosed on liver biopsy as you can see here. Next slide. There's no specific treatment for liver disease at this time. We are looking at gene therapy, and that's currently being studied. There's also some enzyme replacement therapy for the lung disease part, but liver transplant is the option at this time for severe progressive liver injury. Next slide. Now on to autoimmune hepatitis. This one's a little more common. So this is a global disease. Incidence is about 0.3 to 4 cases per 100,000 children. Females account for still 70% of the cases and 50% in less than 40 years of age. It is a common cause of chronic liver disease, and it accounts for, you can see there, almost 3 and even up to 6% of liver transplants in Europe and the US respectively. Next slide. There are genetic factors that are underlying autoimmune hepatitis, where you can see with different antigen presenting. There's also triggering factors, where it's infections and medications and different toxins. Next slide. Up to 45% of patients with autoimmune hepatitis are diagnosed with a concurrent immune-mediated illness, such as celiac disease, thyroid disease, inflammatory bowel disease, or even PSC. Next slide. There's a lot of diseases associated with autoimmune hepatitis that happen outside of the liver, as we kind of briefly touched base with the celiac and the thyroid disease, but you can see there's a whole list that go along with it, and they're all related to the immune system. Next slide. So what are the manifestations and what do we see clinically with this? This is a little different than what we were previously talking about with the other 3 diseases, but these patients still can have fatigue. They can have the large liver and spleen. They can get more joint pain. They can also have fever, or they can be completely healthy and asymptomatic and not know about it for some time. Next slide. We have created some criteria to help us define autoimmune hepatitis, as you can see here. Next slide. So then when we come to treatment, what are our goals of treatment? We actually have treatments for autoimmune hepatitis, unlike some of the other diseases. But our big points are disease remission. We don't want relapse after treatment withdrawal, but it is likely. Treatment failure and incomplete response. And then also making sure we're monitoring for drug toxicity. We do have medications that treat these drugs, or excuse me, treat this disease, but they can have their own side effects. Next slide. Disease remission, that's our main goal. You want the symptoms to go away, you want the liver injury to resolve, and you want the labs to normalize. 65 or even up to 80% of patients within the first 18 months and 3 years of initiation will develop, initiation of treatment actually will develop disease remission. And 10-year survival is about 90%. Next slide. However, with all of that disease remission, we know that 50% will develop relapse at some point, and even up to 70%. So this is where we're constantly monitoring, even if we can get pediatric patients off of medications for if they have disease remission, they may have to be restarted at some point later if they have relapse. Our mainstays for treatment at this point are steroids and immune modulations. So they are medications that we want to minimize as much as possible, but make sure we're treating the disease. Next slide. Unfortunately, there are times of treatment failure where patients can have worsening symptoms, worsening labs, progressive injury, and even more signs and symptoms of worsening liver failure. This is where a lot of times they are on the higher dose of immunosuppressive therapy and they can still develop this. At that time, next slide. Once treatment failure, really the long-term therapy becomes liver transplant, especially if they're in liver failure. And some patients will present in liver failure as their first thing. As we talked about, they can be completely asymptomatic. Next slide. Now on to non-alcoholic fatty liver disease. Next slide. This is a spectrum of disease ranging from just bland fat in the liver to where we actually have ongoing injury, fibrosis, and inflammation in the liver. Next slide. You can see here, this is 176 children looked at in the Pediatric Non-Alcoholic Fatty Liver Disease Clinical Research Network. And at the time of diagnosis, 30% of them had significant injury with significant scarring. And about 40% had definitive NASH, which is more the injury with inflammation and scarring. Next slide. Clinical features that we see, these are the kids that have increased waist circumference or abdominal obesity, insulin resistance, or pre-diabetes. It is more common in Hispanics. There are some genetic factors with it. More the peri and post-pubertal kids are more at risk, and labs are associated. Next slide. It is the most common cause of pediatric liver disease at this time. We don't fully have the incidence of it, but it is common. Next slide. You can see the prevalence here where it's 0.7% prevalent in 2 to 4 year olds, but obese children by ALT elevation, it's almost close to 40%. Next slide. There is a 4-fold increased risk for Hispanic children, as we talked about. It's also increased in Asian children and white children. Next. So we know that the prevalence of pediatric NAFLD is paralleling the growing prevalence of obesity in children or in adults, actually. It varies with the population that is screened and the level of risk and how we follow it. We kind of look at different screening modalities. None of them are perfect. We do notice higher in certain populations, those in overweight and obese children, males more common than females, Hispanics more than other ethnicities, and then children that have prediabetes or type 2 diabetes and obstructive sleep apnea. Next slide. How do we screen for it, since it is the most common pediatric liver disease? Next slide. So ALT is one of the labs that we look at. It's a marker for liver and cell injury. However, it's not perfect. We have to decide what is the actual cutoff. So if you look at every hospital around the country, they have little different cutoffs for ALT, and it's based on norms for that region. And they just use a whole group of patients and figure out what the norm is. This doesn't exclude patients that are overweight or patients that have liver disease. So there was a study that was done to say what should be the normal for boys and girls across the country without liver disease. And you can see here for ALT for boys should be around 26 and for girls should be around 22. So these are the numbers that we use, even though your hospital's lab workup may say that 50 is normal. Next slide. We recommend that screening should be done between 9 and 11 years of age for anyone that has for any child that is overweight or is obese. And overweight with additional risk factors is always important. And those include the prediabetes, dyslipidemia, elevated triglycerides, things like that. Next slide. We may screen earlier if there's a family history of NAFLD or NASH or other risk factors. And we may end up screening siblings and parents of children with NAFLD if they have known risk factors, as we know there are genetic predispositions. Next slide. Currently, our best test is ALT, but it has its limitations, as we talked about. If it's persistently elevated more than 3 months and more than twice the upper limit of normal, we should be evaluating for non-alcoholic fatty liver disease. And an ALT greater than 80 is always requires more workup at that time. Next slide. So ultrasound is something we commonly use in pediatrics. It's non-invasive, doesn't require us to put kids to sleep or sedation. However, it's not recommended as a rule-out test for non-alcoholic fatty liver disease. It is routinely used, though, to rule out other causes of liver disease. Next slide. How do we diagnose it? Next slide. It is a diagnosis of exclusion. This is just a list of diseases that we like to rule out. If a kid presents with elevated liver enzymes, there's a whole host of diseases here that we go through and some other ones that aren't even on the list. Next slide. So it's kind of putting everything together. We're looking at those labs. We talked about how they're not perfect. We've done usually an ultrasound to rule out other things. And a lot of times we'll do a liver biopsy, as that are still our gold standard. Next slide. How do we treat it? Next slide. The goals of treatment. We want the NAFLD to regress or improve. We want to be resolution of the NASH, which is the inflammation part. Next slide. We also want to see a decrease in adiposity and improvement in the other things that are outside of the liver. So the triglycerides, we want those to improve, the blood pressure, the insulin resistance, or prediabetes. Next. So what are our potential treatment options? You can see up here that these are kind of things that most people are aware of, but lifestyle is our number one that we go after. Next slide. Lifestyle modifications to improve the diet and increase physical activity is our first line, and it's our first treatment in all children with NAFLD. Next slide. We try and avoid sugar-sweetened beverages, increasing exercise, limiting screen time, and do a healthy and well-balanced diet. Now, as parents, you guys know this is all difficult, but these are our goals, and we usually will target 1 or 2 small things that actually can be achieved and not everything at once. Next slide. We don't currently have any medications available to treat NAFLD. there is a lot of studies ongoing, and hopefully some will be coming down the pipeline soon. And in certain select cases, we actually will look at bariatric surgery for those selected adolescents that have a really high BMI with non-cirrhotic fatty liver disease and not having any other comorbidities. Next slide. Thank you. I know that was a whirlwind trying to get through the top 5 liver diseases, and I'm available for questions during the Q&A. But thank you for listening.
Thank you so much, Dr. Mavis. Encourage everyone to use the Q&A box to put their questions. Let me just start with Dr. Mavis real quick, and then we'll circle back. I think we've got about 10 minutes for some questions. Dr. Mavis, in terms of the NAFLD, it's an area it's new and it sounds like it's growing. Can you tell us at Duke, how do you interact with those kids who potentially are not responding to therapy? Is it a referral from a different clinic that is seeing a lot of these patients, only a few of which will need, more specialized care? Or how is that team integrated so that everyone is on the same page with therapy?
That's a great question. At Duke, we're actually in the process of building out our pediatric NAFLD team. So we have kind of right now 2 different setups. We have a healthy lifestyles program that helps with all children who have obesity and addresses not only the fatty liver side, but the blood pressure and the diabetes part and all of that. So we work closely with them since the majority of patients go through there and the majority of referrals to liver clinic come from there, although any pediatrician can refer to us. Once you get to the liver clinic, we actually work with the dietitian and social worker and the nurse team. The dietitian is a big part of our program, working with the families to identify little small things and changes that we can make that can have big impacts and big effects. We are working hopefully to get set up with a exercise physiologist in the near future so that we can also work with the families of like what can be done at home to increase exercise. Not everyone lives in an area that they can go play outside, and now that it gets dark at 5 o'clock, you might not want your kids outside when it's dark. And so we're really trying to team up and say what is the best thing. At some other programs across the country, they actually have access to, it's almost like a fruit and vegetable or a produce pharmacy, so where you can write scripts so fresh produce can make it to families' home with all of the food deserts that we have, especially noted in the pandemic. So it's a group event and a team sport, and we are always trying to find ways that we can encourage and do more things at home and also make it easier for the families to have access to the healthy foods that we would like them to have.
Thank you. Thank you very much. Question now for Dr. Superina, and then back to Dr. Mavis. Rick, can you tell us over the span of your career, there has been an impact of medical therapies that have made some diseases less commonly leading to transplant, and maybe there's some that are on the rise. Can you give us just a snapshot of what you've seen change from a disease that we don't need a transplant as frequently, and maybe your insight on disease that we are transplanting more frequently nowadays?
Yeah, thanks, George. I think cystic fibrosis as a reason for transplantation was not that uncommon, but I think the therapy for cystic fibrosis has gotten so much better over the last decade that I think it's almost gone away as a reason for transplanting the liver, even the lungs to that point. So that's been a great advance in that field. The hepatoblastoma seems to be on the rise because of the higher incidence of hepatoblastoma in young children and premature babies in particular. So as the incidence of hepatoblastoma rise, it'll be interesting to see what sort of impact that will have on transplantation. We can still resect the majority of those patients, but I think there's going to be a hard core of patients who are unresectable, and I think the incidence of transplantation for that will rise. We always talk about biliary atresia as being the commonest cause for pediatric liver transplants, but in fact, in 1 year, a few years ago, we actually transplanted more children for hepatoblastoma than for biliary atresia, which was kind of interesting. I've got to tell you that the statistics for transplantation have remained remarkably stable in my entire career. There's about 30% of patients who have biliary atresia. Now, I think for those kids, the biggest improvement will be an earlier diagnosis, like what Alicia alluded to in the past. We've talked about, how I think there was a recent study from Houston that where you can increase the diagnosis and make it at an earlier stage in life by simply doing serum bilirubins at a week or two of life and measuring your direct hyperbilirubinemia. The stool card experiment, seems to work well in Asia. I find the stool cards really confusing. But I think vigilance and public health policy towards better early child care will make an impact in biliary atresia. That paper that we published a few years ago from the Children's Network, there was a significant difference in the outcome in the patients who were diagnosed and treated earlier than 30 days of age. But really, the median age at diagnosis and treatment has remained remarkably stable between 50 and 60 days. And until we make an impact in that, I think biliary atresia is going to remain with us. But earlier diagnosis and concentration of biliary atresia treatment in centers of excellence, I think will go a long way towards diminishing the cause for transplantation, or at least pushing it forward into, we're seeing adults now who need transplantation for biliary atresia. The metabolic diseases, I think they are what they are. Until we have gene therapy, I don't think we're going to really make much of an impact in those. And it's been, Roy Kahn once said that some treatments are just around the corner. But then he said, but it's been a really long corner. And we keep waiting for breakthroughs in things like oxalosis and, the maple syrup urine diseases and things of that nature, that urea cycle defects, where gene therapy, cell therapy has come and gone without much of an impact. The whole business about liver in a box for acute liver failure really hasn't worked out. So I don't see as much liver failure as I used to. The acute liver failure patients, maybe the treatment for that has gotten better from a hepatological point of view. But so, hepatoblastoma, I think, may be on the rise, and maybe biliary atresia will diminish over time.
Thank you. Dr. Mavis, do you have any thoughts on trends that you've seen in your practice in terms of increasing or versus decreasing incidence for transplant?
I agree with Dr. Superina on the cystic fibrosis that has been decreased over time. Acute liver failure, we are seeing less transplants for as well. We're starting to identify, we're doing a better workup, I think, and identifying more things early on. But also now looking at some of these immune mediated, which there's an ongoing study right now that started trying to look at identifying immune mediated and treating those. Hepatoblastoma, I agree with Dr. Superina. That one is also, that's a tough one because it's also a lot of center dependence too on hepatoblastoma of transplant versus resection. I'm not a surgeon, so I won't go into all those details. But I think fatty liver disease with its rise, it's now number two reason for transplant in adults. I'm concerned what that's going to do in pediatrics, if that's going to start happening on the pediatric side. We've got to get a better control on that, and we don't currently have any treatments. And then we're better identifying alleles and alpha-1 and those kind of things earlier on in life. The metabolic diseases are an area where we are identifying them earlier. But again, we need more gene therapies. We are doing more transplants for some of the metabolics, and because we don't have gene therapy yet, but hopefully with more gene therapies coming down the pipeline.
Perfect. Thank you. There's a question for you, Dr. Mavis, from one of our attendees. She's asking, what is the correlation in your experience between immunosuppression transplanted patients and other immune diagnoses such as food allergies or potential skin conditions like eczema, dermatitis, asthma? Is there anything you can comment on, or our other panelists can comment on about that association?
We do see, so post-transplant, I'm going to talk more about post-transplant kids right now. Our kids that are post-transplanted on tacrolimus and some of the other immunosuppressions, they do have an increased risk of some of the allergic things like eosinophilic esophagitis. They can have skin rashes associated with that. There are times that we have to adjust the immunosuppressive regimen or even switch drugs completely because of that increased risk, and to actually treat or get the rashes under control of the EOE. So that is, it's not common, but it's something we see that we take care of. And it is a predisposition with those medications and with tacrolimus, what the cells that we're actually blocking are ones that actually help with the allergy side. So we do see that pre-transplant, we don't see it as much with some of the 6-MPAs, thioprin, and things of that sort. But post-transplant, yes, it is something that we see and that we have to address for sure.
Thank you very much. There's some questions coming in on the chat. I think I'm gonna encourage our panelists to answer those questions. We're also gonna have a little bit more Q&A time in a little bit, but right now I'm gonna move on to a really exciting part of our story. And I wanna thank Dr. Mavis and Dr. Superina for kicking us off in such a spectacular fashion. Our next speaker is going to address how it is to navigate the journey of having a child with liver disease. Carla Whitehead Sims is the mother of Lauren, and here is their story.
Hi, good morning, and thank you, Dr. Mazaregas. I will mention that Dr. Mazaregas was part of the dream team that was involved in Lauren's transplants. It was headed up by Dr. George Reyes, and obviously I'm eternally grateful to these men. So I'm not a professional speaker. I'm going to try to do this without getting too emotional and keep it, on our story. So this is my daughter, Lauren, and she is 27 years old. She is 25 years out now from being transplanted. And as you can see, looking healthy, looking good. She is usually the exception to the rule. I will say anytime they would say, well, there's a slim chance that this would happen, it happened. So she came into the world rather dramatically too. She almost was born in Oakland on Fifth Avenue, barely made it to the hospital. She was under 4 pounds. They whisked her away from me. And as a parent, that's scary. You could see from their faces something, wasn't right. The fact that she was so small was actually due to a separate issue, a tear in my placenta in the 3rd trimester. But she was very jaundiced. And, as a parent, they start throwing out words to you like bilirubin. And, as the testing went on, biliary atresia, Alagille syndrome, things that probably strike terror in a parent's heart hearing that, especially when they use the word transplant. I literally almost passed out and had to sit down and sorry. And you're trying to listen to what they're saying. I would take a notebook, write notes down, but it was, a scary time, and you're hearing terminology that you had never heard of before. So she was born in October. By Thanksgiving, she was diagnosed, and she had one of the rare diseases, Alagille syndrome. And with that, as you've heard earlier, the bile ducts obviously are missing, not working right, and the bile backs up, and she was yellow, extremely yellow. And she also was itchy. She would, just sit and rub her feet on the floor trying to get some relief. We used Actigol. There were other things that they, tried to do for her. And while most kids, as they said, are later on transplanted, she got put on a transplant list for her first birthday. And we waited probably, it was, a year. And as one of the doctors, had indicated, that is a weird time because you're literally hoping, somebody passes away so that your kid can, have a shot at a normal life. So December, a year later, rolls around, and we got called to come in as backup. A child was getting transplanted that had complications, and they weren't sure if they would be able to transplant. So because we were local, which was a godsend being so close to Pittsburgh. We were their backup plan. And so again, as a parent, you're hoping to God that that first child gets the liver. And we were willing to wait our turn for her to get hers. So fortunately, the first child, they got to be transplanted. We went home and were called back, I think like a week or two later. And Lauren received her first transplant, which was a split liver. It was an adult liver cut down. And, as one of the doctors said, you go through the sonograms every day. And I think it was actually the last day of sonograms that they found the hepatic artery had clotted off. And she went into the hyperbaric chamber. If you can move up 2 slides, that would be great. There we go. Into the hyperbaric chamber. And, while they relisted her for transplant. So funny story now, wasn't then, but there was a fellow from Greece who was explaining to me about the hepatic artery. And I said, well, is there a surgery? And in my mind, that included transplant. In his mind, it was just a surgery to fix the hepatic artery. And so he, looked at me and he's like, no, surgery is not an option. Well, I was like, oh my God, I'm thinking there's nothing they can do for her. And he must have finally realized the terror in my face. And he said, we can retransplant. And I remember just grabbing his lapel and saying, you could have led with that, So she was relisted, and we were waiting, to get the second liver, and we did. It was a child's, which again, that not even getting into the psychological of that, especially at Christmas. And the joke at that time was that there was, that's when the Tickle Me Elmo dolls were so hard to get. And we were joking that it was easier to get a liver than a Tickle Me Elmo doll. But she ended up getting both, so it worked out. The second, liver, and I guess one thing as a parent too, that first time that you see your children, see your child for the first time post-transplant, and you can see literally the whites of their eyes, their pink skin, like it's a moment you will never forget. So second transplant, I'm thinking, okay, we got this, we're good. Little Calamity Jane here can't, just do the easy route. So, and a vein had wrapped around one of her arteries. So literally Christmas Eve, Dr. Reyes came and said, gonna take care of this for you. So great. And he did. And he came in afterwards and he told me, this was the first time I've tried this process. We literally shaved the vein off of the artery. And I'm like, well, really glad you didn't tell me that, ahead of time. So second transplant, was a keeper. And, they tell you all the things that can happen in that first year. And they say usually you'll get 1, maybe 2. Well, not her. She had a rejection. She had sepsis. She had some bleeding from being scoped that was pretty substantial, and required a drive in the snowstorm to get down to the hospital, to make sure she was okay. She also had PTLD, which again, to parents, keep a notebook. Dr. Reyes had, when he went through the litany of things that could happen in a year, PTLD, for some reason in my mind, was associated with cancer. And I, so when they said PTLD, I was having a meltdown. And it was the day that Princess Diana was in the accident and died. And I'll never forget standing out in the hall, all teary-eyed and crying. And one of the nurses said, oh, are you, sad about Princess Diana? And I'm like, no, I mean, I am, but I said, no, my kid has PTLD. And so Dr. Reyes had been away from the hospital. He called me, talked me back down off the ledge, said, she's going to be fine. You need to calm down. And, truly, he was great with the parents, like always that voice of reason, making it feel like they were going to get a tooth pulled instead of a liver. So he was very helpful in this process, and keeping communication and a good relationship with your surgeons is always a good thing. So, we had like a 2-month stay at the hospital. And then you're released to go home, and, parents were nervous, anything can happen that's going to take you back to the hospital. Fortunately for us, we only lived 15 minutes away. So that was a good thing. And while at the hospital, I want to say too, like they were so good to my son also. They brought video games in for him. And, as a family, it affects the whole crew. Sean had been the firstborn and was the star of the show. And all of a sudden he's taken a back seat to his little sister and, dealing too with all the drama, his parents being upset and scared. And, so it takes a toll on all siblings. So it was nice that the hospital catered to his needs as well and tried to make him feel included. So we cruised along pretty well for a while, and then she hit kindergarten and vision and hearing became an issue. Her, hearing is actually a separate issue. She has a moderate hearing loss, wears hearing aids. The vision, at first wasn't a big deal, but as she got older, it really was progressively getting worse. And so we started seeing specialists, and this 1 in a million, which Alagille's is rare to begin with. Now all of a sudden she gets tested for vision. They find out she has RP, retinitis pigmentosa. And again, you start hearing words like that and like rod and cone dystrophy. And you're just like, is this, ever going to end? And they also, at that point, found a Chiari malformation type 1, which is when the base of the brain pokes down into the spinal column. And when she walks, a lot of times she looks like she's been out drinking. Her balance is really bad. She fortunately didn't get the seizures and the stuff that comes with that. So the vision, why I'm talking about it, is we thought RP was just, again, another issue unrelated to Alagille. But as we started seeing specialists, we found out that there is a very minute sector of Alagille patients who develop this strain of RP. So once again, our winner here in the lottery. So she, the fortunate thing about her strain of RP with Alagille is that her vision has remained somewhat stable. It was on a really bad decline, but all of a sudden kind of leveled out. And most people with RP, by the time they hit college, go completely blind. And so she is legally blind, but she has vision enough to navigate and, at least get around, read, do things like that. So they had wanted to switch her from Prograf to Rapamune because the Prograf seemed to be making it worse with the vision. The Rapamune was not working well with her liver, so ended up going back to Prograf. But fun fact about Rapamune is that it can give you a false positive on pregnancy tests. And, since children's deals mainly with kids, I don't even think they realized that. I ended up Googling it you know, trying to find, because I just thought it was odd. And sure enough, yeah, that was a fun fact about Rapamune. So she went back on the Prograph, and yeah, that took about 10 years off of our life, Laura. So back to the Prograph. And she's been, you know, maintaining, you know, changing the Prograph to Rapamune kind of set us back a little bit. And she was on prednisone for a good while, and you know, having everything seems to be now back to normal. So we've been focusing more on the vision at this point. Lauren finished college. She was a very big advocate at Slippery Rock for kids with disabilities. She mentored children with autism. She has, you know, is living the normal life. If parents are watching whose kids have not been transplanted yet or are, it's a rough road, I won't lie to you. I found that a sense of humor helps immensely, and I have a very twisted sense of humor. But right before she was transplanted, we were at the beach, and because she was so yellow, when she tanned, she would turn like literally green. And I'll never forget, you know, if people ask nicely, of course I explain to them, but I'll never forget this one woman coming up to me and going, "Do you know your daughter's green?" And I just like looked her dead in the eyes and I said, "Yep, that's what a one night stand with a Martian will do for you." And she just looked at me and walked away, and I just laughed. But we'd have people come up to us, you know, "Do you know your kid's yellow?" And her dad and I would look at each other and we'd be like, "Oh my gosh, no, holy cow, Chris, look." So we did, we kind of used a sense of humor about it. Lauren kind of adopted that defense mechanism too. She was at the pool in a bikini, and of course transplant kids have the lovely Mercedes Benz, I call it, scar. And a girl came up to her and she's like, "What's wrong with your stomach?" And this one looked her dead in the eye and said, "Shark attack." And the girl didn't know what to say, walked away. And you know, so we've used a sense of humor to try to cope with the drama that has been throughout our lives. We've tried to not make that our entire life. You know, you do normal things. And a very wise gastro doctor had told me too, Dr. Putnam, to not treat them like China dolls, to not spoil them, or he said, "You will have a nightmare on your hands." Try to make their life as normal as possible. And I hope that we have, and I feel that we have. Also, as a parent, you know, don't be afraid to advocate. Dr. Mazaregas can attest to the fact that I can become a bit of a mama bear when I feel my cubs being threatened, or, you know, if I feel something's not right, I would speak up. And, you know, as long as you do that in a respectful manner. But don't be afraid to ask questions, because, you know, I had no medical background going into this. And it was funny because as back then, Eligiles there wasn't as much knowledge about it. And we would have residents coming in asking us information about it. When we go to a new doctor, like, you know, I usually spend the first 10, 15 minutes talking to them about Eligile syndrome, because it isn't that, you know, prominent. So, you know, this has been our journey. It's been a rough one, but wouldn't trade her for the world. And actually made it through without blubbering too much. So just wanted to tell you, keep the faith. As the doctor and, you know, the people speaking before me had said, you know, we live in a time where transplant it's, you know, the odds of survival are so great. We were lucky to have Dr. Starzl, who I've had the pleasure of meeting, so, you know, a couple times, and I'm thankful for it. So that is our story. Good luck to all of you, and thank you for letting me share it.
Thank you so much, Carla, and it's great to see you, Carla and Lauren. We really thank you for your sharing all that insight into your journey and the challenges, and it's great to see you. We really look forward to having some questions and some time after our next speaker too with you and Lauren. Now it's my privilege to introduce Brittany Smith. She's gonna talk to us about how to talk to family and friends about your child who has liver disease, and maybe she'll include some Martian stories in there as well, as we heard. But Brittany is a certified child life specialist and family life educator who works with the patients at Lurie Children's Hospital in Chicago. She's master's trained from the University of Missouri and has had a decade of experience working as a child life specialist. And she's presented on multiple topics in diverse communities. And she's been also active in working and presenting for the United Network for Organ Sharing, UNOS, on the impact of transplants on patients, siblings, caregivers, and the communities that support them. So please welcome Brittany on her topic of how we communicate with siblings, families, and friends about liver disease. Thanks so much, Brittany.
Thank you so much. And good morning, everyone. And I just want to say how honored I am to be able to share this morning with you and share a little insight that I've gained over the last decade in working with families that have gone through transplant and helping support them. So I was asked to talk a little bit about how to talk to siblings, family, the community surrounding transplant, and in thinking about how to do this most effectively and efficiently in this time frame, I wanted to really address some of the common concerns that that I hear when I work with caregivers as they're, wondering. And actually, next slide, please, to common concerns of who do I tell, what do I say, when do I tell whoever we decide to tell, how do I support the siblings, and how does this impact family and friends? So throughout this presentation, I'll probably refer to the child that's receiving the transplant as the patient, to then make it more clear as I'm discussing siblings. So I just want to be clear with that. If I'm referring to patient, referring to your children that potentially need transplant. So next slide. So the who, what, and when of how to discuss and who to discuss this with. And this is really a big piece and a big question for so many families. As far as the who, I always say that's between you and your child, you and the patient. If your child is of an age where they can have any input, please give them some input, some choice. There's not a lot of choices in the grand scheme of having a liver disease requiring a transplant. And so any small choices that can be given to the patient throughout the process can be really helpful in helping them cope, giving them some autonomy. So who does that child want to know? Recognizing that there's going to be some non-negotiables, meaning if your child is in school, someone at the school probably needs to know at least the basis of what's going on so that it can be negotiated with the school on schoolwork and pushing back deadlines, things like that. Recognizing there's also going to be some non-negotiables as far as what you as caregivers need. So keeping in mind, let's say the patient says they only want your core immediate family to be informed about a transplant needing to take place. But you as a caregiver are really recognizing that, let's say your brother is someone that's really important and you need that person to know everything that's going on to help you cope, which is so vital because if you're coping well, that's going to benefit the patient and the siblings. So recognizing that you may have to say to the patient, I hear you, you just want it to be us that knows, but I really need, Uncle Ryan to know what's happening as well, and here's why, but I will give you choices and other people. I bring this up because I have had many patients and caregivers that when the patient's has been extubated, is alert again, and they're finding out, oh my gosh, everyone knows I got transplanted. How does everyone know? And it can cause some friction. And so really, I encourage families to have this conversation ahead of time, if possible, recognizing that there's so many different situations and circumstances, but giving them the choice and having this conversation ahead of time can be really beneficial for the whole family unit. Additionally, as you may have your own support system that you need, also encouraging the siblings to identify people that they feel like are really important in their coping and in their ability to get through this process. Because as I know it's been mentioned before, the liver transplant process does impact not just your acute family, but your greater extended family, but also the community that supports you. So again, giving the child with the who to talk to, who do they want to know. Obviously, you can't give your child full autonomy on that most of the time, but figuring out a way to compromise so they have some choices. Because we want to remember it's happening to them, to their body. Yes, it's impacting family and siblings, but how do we find a good balance between those two things? And so that's some of the suggestions I'd have there. When to say things about the transplant. I believe that as soon as you know a transplant is on the table, starting that conversation. Kids do pick up on things that are said and not said, as I think we all know, and the body language, the changes in schedule, just some of the normative things that maybe take a little slight tinge different when there's more doctor's visits, or you're mentioning that thing that might happen and not saying the word transplant. Kids are going to pick up on all that. So really having that conversation as soon as possible, and making sure that siblings are informed before almost anyone else. The reason I bring this up is because in the not so far past, had a patient whose sibling learned from a guidance counselor that their sibling had a transplant. Really well-intentioned counselor saying, oh my gosh, how is your sister? How's the transplant? Like, is everything okay? And the patient was like, what are you talking about? They knew their sibling was in the hospital. They were not aware that they were having an organ transplanted. So really thinking of a way to discuss with siblings, again, as soon as possible. And then that leads to the next thing about what do you say then? How do you explain, or what's too much information? What's not enough information? And obviously that's so individualized to your family, your child, where they are developmentally. But the things that I say, regardless of age and development, are making sure that you're being honest, that you're delivering the information at a level that is developmentally appropriate for your child, and then things that are being clear and concise. So when we're talking about being honest with these siblings, please know that it's okay to say, I don't know, I'm not sure, we're still working on that, we're not sure yet. All of that's okay. Your children are looking to you for that kind of guidance. And it's okay to say, I don't know, because there are going to be quite a few unknowns throughout this process, as maybe, we don't know when the liver is going to, be transplanted, or as you wait for labs to decide what the next course of action may be. So through the unknowns, it's okay to say that. When we talk about also providing information, it's okay to say, I don't know, but let's find out. And then talking with siblings on who are the safe, trusted people to get information from. So think about the amazing physicians we've already had speak today, asking them questions, asking your APN, the bedside nurse, child life specialist, social work, dietitian. Your medical team is a great place to ask for information. I also then encourage caregivers to talk about where not to get information from. Joining there are obviously Facebook groups that are wonderful, but being mindful that all the information on there may not be fully correct, or maybe one person's very specific situation. I've had teenagers be like, well, I saw on Reddit that this happened. I'm like, okay, great. That is this one situation, very, very different than yours. So really asking the people in your medical team as much as possible, because they're going to know answers that are specific to your family, your child, your patient. Ensuring that information is developmentally appropriate. So what information, let's say your developmentally appropriate 17-year-old sibling needs to know may look very different than how you explain the liver transplant to the 5-year-old. Let's say, for example, an intubation tube may be just a lot of information for a 4-year-old that hasn't seen the sibling yet. And so maybe saying, as you're preparing the child for the transplant's going to happen, oh, your big brother's going to have a transplant. Maybe you don't have to go into the intubation tube right away. That might be too much for a child at that developmental stage. But that information about after they get the transplant, they'll have a breathing tube in for a while. That might be exactly what helps your 13, 14-year-olds really feel more concrete and connected to the whole process. We, as child life specialists, typically our profession would always say the more information, the more honesty and truth, the better. We suggest finding a way that siblings can see the patient, whether it be through photos, videos, in person. All of that obviously depends on the hospital and COVID and visitor policies at the moment. But I want to be clear that we always suggest siblings are prepared by a professional ahead of time of everything that they'll see, go through all the sensory information as to not overwhelm the child. Also thinking about what to share with the wider family. Again, what the wider family or your support system, the community knows will obviously depend then on that initial discussion that you had with the patient. Who do they want to know? Is it okay that their second grade teacher from a few years ago is aware because they're helping provide support to, maybe the sibling that's in their class? There are some really great tools. If the patient does say, I don't care who knows, everyone can find out. There's some really great tools out there that can help caregivers keep the community informed without having to respond to 25 different text messages or phone calls a day, which I've definitely seen quite a few caregivers have to go through. So one thing I say is, if you, this is a great role, actually, we'll kind of talk about this in a little bit, but a great role for the extended family or community support member being the contact person, and the caregiver gives, let's say Susan, the information, and then Susan disperses it throughout everyone as they see fit, or answering those questions, so that the caregiver who, as I think Carla did a great job explaining how much is on the plate, reducing some of those things and kind of allocating some things that can be done. And then last, clear. So, we want this information to be clear and concise. So oftentimes I'll hear people say, oh, your brother's at the hospital, he's sleeping. And one thing that I always encourage caregivers is to really be specific about the difference between what sleeping at home is versus when we're at the hospital. And so I suggest and often encourage the utilization of, concrete words. Your brother had anesthesia. Anesthesia makes so that you don't feel any pain. You're not remembering these. Your body is at a really nice sleep, but not one like we could wake you up easily, that you would feel things, different things, helping differentiate, because, oftentimes kids take things so literally, especially that school age group. So if you say their brother's sleeping, they think they can give them a call and they'll wake up, and that's not the case. So being clear, being concrete, that will be really helpful, because so much will feel up in the air, unknown, and having solid language to hold on to will really benefit. Okay, next slide, please. Okay, so these are some frequent questions that you may hear. And I just want to put it out there right now. I'm not going to have the time to go through great answers for every single one of them, but I want you to know that these are all really common questions that we hear from siblings. Where did the liver come from? I should say siblings, and as well as the patient that will be receiving the transplant. Where does the liver come from? Obviously, that answer is going to be different depending on if it's a living donor or a deceased donor. Did someone die? And again, I encourage people to be honest, but recognizing that, again, depending on your child's development, that's going to be maybe too much information. Also recognizing, as people have different belief systems, different ways of discussing death, again, that's something that we would want to individualize to that family about what that conversation looks like. But that is a question that is very common. And I always like to give caregivers that heads up, because it can be startling, I think, to have a young child ask, like, did someone die? how does it get in my sibling is always a really great question. And that's typically when we have the opportunity to talk about, opening. And I think Carla called it the Mercedes-Benz scar. And so, talking about that, showing we have prep dolls, at least at Lurie, we're really lucky to have that resource. But, a lot of clinical educators or child life specialists, depending on where your transplant home is, we'll have some resources like that can be utilized, and you can discuss a little bit more what that's going to look like. Will my sibling die? That is a question that I think is the most gut punching for a lot of the caregivers I work with, understandably so. It is a question, though, that does get asked very frequently, especially if the liver came from a deceased donor, and the child knows that, then there's that connection. TV and movies and the internet and as a whole sometimes really glorify, or I hate to use the word glorify, but maybe over simplify the process sometimes, and then make it this big, everything goes this one way. And so sometimes kids really have a set idea in their head already about what a transplant can look like. So again, having concrete information. Sometimes when a kid asks me, will my sibling die? I talk about how skilled the care team is, how often they've done it. I'm very lucky. I work at a hospital with Dr. Superina, so I can say this is a world-renowned doctor. He does such great work, and they have incredible nursing staff. And we really just talk about the tools, the people, the medicine, all the things that we do to keep a patient's body safe. And do I get to see them? And again, that's going to depend on your institution. As a child life specialist, I do a lot of virtual sessions and prep with kids. Obviously with COVID, restrictions were pretty tight. And so we'll work on different ways to provide support where we're able to prep a sibling first and then engage with the patient that's been transplanted. Next slide, please. All right, so a couple really quick challenges facing siblings. There's going to be interruptions to your family dynamics. Let's say the oldest child is the one being transplanted, and as we heard from Carl, it can be a long journey. Maybe that middle child now feels like they're taking on more responsibility, a different role. They're having less time, obviously, then with the patient that's been transplanted, as well as interrupted schedule with you all as caregivers. There's going to be changes in schedule, as even pre-transplant, if there's appointments, or post-transplant with appointments, during the hospitalization, all of that changes scheduling. So we encourage, as much consistency with that as possible. And sometimes that's just not possible at all. And we fully recognize that everyone's situation is so unique. And oftentimes siblings just feel really alone and forgotten. We encourage kids to really feel connected to their siblings in a variety of ways. We've done journaling back and forth with the sibling, obviously FaceTime, letters. We've had siblings help decorate the patient's room. Obviously through COVID, it was more give it to the caregivers and the caregivers bring it. And then we would FaceTime, look at how great you did in decorating the room. And then we also really encourage special time between caregivers and the siblings. Next slide, please. The challenges facing family and friends obviously varies again, depending on what your support system looks like. But big thing I always like to tell caregivers is if a community member or family is offering help, they probably mean it. And it's so hard for so many of us to give any allocation or give up some of that control, but it can be super helpful for you as caregivers with so much else going on to allocate some things. So I often suggest to caregivers, develop a list ahead of time, knowing those support people are going to ask, what can I do? And in the midst of transplant life at the hospital, it could be really hard to pinpoint what that looks like. Do you need someone to water the plants? Who's gonna, walk your dog? Who's checking your mail? Small things like that can be really beneficial and help people in your community, in that circle, feel like they are doing something. What to do and when. Identify your people at the beginning of this transplant talk. Having someone, like we said, maybe being the point person for communication. Maybe they're the person doing the caring bridge, or they're giving updates. You give them updates, and then the one person that disperses the rest of the information. Maybe there's someone that's helping you say, like, check, pay your bills, things like that I've just witnessed throughout the years, that families have a hard time being like, oh my gosh, who is going to help with that? So coming with a list of things that maybe could easily roll under the covers throughout all of this process, and having that prepared ahead of time can be really helpful. And again, utilizing that support system. Oftentimes, if people are offering help, they truly do mean it. Next slide, please. So again, kind of summarize tips, giving choices to the patient, to the siblings, who gets to know, to the siblings, what are you going to do to feel connected with the patient while they're in the hospital during that time. I think the biggest thing is trying to create a plan ahead of time as much as possible, creating a coping plan for you, the siblings, ways that your community can support you. And then just remembering to make time, making time for the sibling, making time for yourself. And those things are so much easier said than done. But any ways that you can do those two things, whether it be just 10 minutes of quiet time for yourself, a daily 5-minute phone call with the sibling, anything that just helps them continue to feel connected and helps you feel connected and grounded as well, are just a few things that we could say that would help throughout this process. And that is my time. Thank you all so much.
Thank you so much, Brittany. That was fabulous. We have about 10 minutes for questions, and then we're going to take a lunch break and give everyone a chance to stretch their legs and get ready for the last part of the seminar. But let me get started first with Brittany. Brittany, great presentation. And what kind of advice do you give to the child going through the transplant process, maybe a couple of different ages, in relation to how they should share their story? And what's been your experience? Do you have any guidance about things that would be helpful for parents out there in terms of helping their kids share what they're going through, maybe after transplant, in their social circles?
Yes, absolutely. Obviously it does vary greatly with age. One of the biggest things I think that I'd like to talk with caregivers and teens about, if the teen has said it's okay for me to further provide that information, is the body image piece of a transplant. It was, again, Carl, I think, mentioned that Mercedes scar. It's not one that can be hidden. It's not something small that others won't see or notice. Right. And so talking about that ahead of time, what does the teen, and honestly, in this day and age, really starting at like 9, 10, those body image issues are coming up. So, what is that going to look like? How do they want to explain that scar? Do they want to say it was a really cool shark attack, or do they want to get into, I was born with this disease, or this happened, and I needed a liver transplant. So I think, again, being upfront and honest with what that looks like. I've heard families in the past be, well, there's just going to be a little, and I'm like, well, actually, it's not this little thing. Because you certainly never want a child to wake up with a scar, the way a liver transplant scar looks like, and thinking what went wrong. Because if you're being told ahead of time, oh, it's just a couple inches, little small thing, and you wake up and you see your abdomen looks quite different, that can be really confusing and hard. So I encourage caregivers to be open and honest from the beginning. For teens, we talk a lot about, again, what is that body image issue going to be? Are there going to be issues or not? Some people just think this is a really cool scar and I can't wait to show it off. And others feel really much more private about it. And so we talk about, talking about it on your own time. It is, luckily with the placement, if you're wearing swim trunks and a t-shirt or a full piece swimsuit, you don't have to provide information to anyone about it if you don't want. And so we really talk about, again, it goes back to the, who do we tell? When do we tell them? If a child or teen does not want to say anything, then they don't have to. It is something that they can keep more private than, let's say, like an NG tube or something that was much more constantly visible. So I say, have those conversations as soon as possible so that there can be time for processing, time to develop. What do we want this to look like? What do we want this discussion to sound like? Yeah.
Thank you very much.
Of course.
Question for Carla and Lauren's team. As you navigate getting into adult healthcare and adult transplant follow-up, can you tell the audience a little bit about things that have been helpful for you? Obviously, Lauren's still a young adult. It's exciting that we're looking at a transplant lasting now, hopefully for her, a near normal lifetime. But any insights or challenges that you want to share about transitioning from pediatric care into adult care, and any recommendations that you might have?
Yeah, she is just literally going to be transitioning, but we have in other aspects. And, I found like most doctors are all the same. Obviously at children's, you're going to be coddled a little more. And, with the pediatric element, I've heard that when you transition to adult, there's, they expect you to be an adult and they're not going to coddle you as much. Like they're not going to keep telling you, you need to take your meds, like you need to do it. And you're going to have to take responsibility for yourself, which she has done. Especially, I was so worried when she went away to college, is she going to take her medications? Is she, going to do everything she needed to do? And, so that was like a dry run. And she did very well. You want to weigh in on that? Are you nervous about transitioning over to adult?
No.
No. I think she's been doing this so long
Yeah.
that she's a pro, and everything that could have happened has already happened. So we're prepared for anything.
Now, 25 years after your transplant, can you just brief in general tell us the transplant medicines that she takes right now, specifically for her liver? Can you tell us about that and how that affects your life?
Sure. She takes the Prograf.
Mhm.
What else do you take for the liver? I think
That's it.
That's
No,
it.
They just took me off
And
of
you're on
those.
what, 1 milligram
Mhm.
twice a day?
Yep.
1 milligram twice a day. In one of my encounters with Dr. Starzl, he had, I was telling him about her and he was saying how the doses, and he said, eventually, like if everything goes well, there are kids who actually even go off Prograf or just remain on a very low dose, which she's on. So we've been lucky. She was on Bactrim for a good many years. What else? Anything else? Prednisone. So we have, over the years, there's been a lot as different issues came up. But it's funny, like trying to remember, like even, her journey itself. I was talking to her dad. There were things that I had forgotten that I thought I would never, ever forget. But, 25 years has been a wild ride, and the focus has kind of shifted too from the liver to the vision, just because that was becoming more of an issue. So yeah, she's been good about taking care of her meds.
Is there any advice you can have to patients to help you in taking your Prograf on a regular basis?
I guess everyone's different. I keep mine on my nightstand. So, and with the remembering, like, did I take that in the morning? Because if it's still in the same spot, you don't remember. So I put like a bin on my nightstand so that once I take it in the morning, I put it in there. That way I know I took it in the morning. No, I'm taking the evening. So
That's a great idea. I haven't heard that before, but that's a very simple and great suggestion. Related to, we're almost at our lunch break. I just have one question that came in from the chat, and certainly open up to Dr. Saeed and Dr. Mavis if they can answer as well. I think Dr. Superina may not be able to participate as he's at on board the flight now, but there was a question about complications of immunosuppression, and then whether studies related to potentially removing or lowering immunosuppression existed. And I know for in our experience in Pittsburgh and also at Lurie Children's, we participated in several studies that have looked at this, and some of those may be ongoing. So I suggested in the Q&A that one of the first steps for families who are wondering about studies or treatments in relation to alternatives to immunosuppression would be to touch base with your transplant center and discuss what is available there, either and specifically about which complications you are experiencing or what studies may be available. Saeed and Alicia, do you have any comments that you'd like to add to that question on post-transplant immunosuppression and maybe lowering or withdrawal?
Yeah, I think, I'd like to say, we did participate in a study withdrawing immune suppression, and were successful in getting about a third of patients off without any, so completely off. And the ones who failed did not have any long-term side effects from it. I think, it's something that everybody's going to be continuing to try to do and, work towards. And so it's good to keep in touch with your transplant center and keep asking them every time you go, is there something new that's out there? Would I be eligible for this? I found your mentioning of RAPA causing a false pregnancy test. I didn't know that. The side effects of RAPA I've only found from families, not from like a package insert, because so few people are on it and it's so different for each person that I've learned a lot just from listening to people. But I think hopefully we'll, I don't think everybody will be able to come off of immune suppression, but we should be actively moving towards, if you can't get off, then at least be on the bare minimum, because everybody has their own sort of bare minimum level.
Thank you, Saeed. Well, I think with that, I'll turn it over to our organizer. I think we have a lunch break, and we encourage everyone to be back at 12:15. Dr. Saeed Mohammed is going to kick off the afternoon session, or the latter part of the symposium. It's been a fabulous interaction with everybody, and we look forward to that session. We have 30 minutes to get a snack or a break, and we'll look forward to seeing everyone back at 12:15 Eastern Time. Welcome back. We're looking forward to the closing part of our symposium today, and it's been really fantastic to have such a diverse group of presenters that have really talked about so many important aspects, from the surgical aspects to the medical therapies to the patient perspectives. And we're going to continue now with a great presentation from Dr. Saeed Mohammed, who's the medical director of hepatology and liver transplant at the Northwestern University and Lurie Children's transplant program. He's an associate professor of pediatrics there. And he's going to be speaking to us about the management of the daily life of a child with liver disease. And we'll look forward to Dr. Mohammed's presentation. Thank you so much, Saeed.
Thank you, Dr. Mazariegos. And I'd like to thank the organizers for inviting me to present at this venue. I have to say, I've learned a lot from talking to families, especially in regards to managing rare diseases. Every family has kind of their own point of view and their own challenges. And so it's helpful when you have only a small set of patients to be able to talk to people from across the country. Next slide. So what is a chronic disease? A chronic disease is a disease of long duration, one that progresses slowly with little change and interferes with daily functioning. It can affect a child's physical, psychosocial, and cognitive development, and it often affects the entire family. Next slide. So living with a chronic disease takes a toll on the patient and the family unit. Many diseases, such as the diabetes, cystic fibrosis, and asthma, have been studied, and all have shown lower quality of life in children and in the families. And then families often have greater medical costs than their healthy peers, and some parents may be unable to change jobs due to loss of benefits. And so they may be stuck in either, where they're living or in a job that they don't particularly enjoy. Next. So diagnosis of a chronic health problem can cause a crisis in the family. All chronic health problems create common challenges for patients and families, and the effects of these challenges on the family really are dependent upon the family members' coping abilities. So some families are able to cope better, and others who may have fewer resources are often strained a lot. Next slide. So some of the common concerns are financial concerns. This is always a big problem. Paying for treatment. If you have to travel very far, living expenses at that health facility can be difficult. And caregivers' job loss because of time they're not at work. If somebody has to stay at the bedside for a long period of time, giving medical therapies at home can be very stressful, especially if you have to give something like IV therapy or if your child has a central line. Disruption of family life. You have to think about how you're going to take all these medications. If you need things to be specially cooled or things to be sterile, it's difficult to take regular vacations and do regular things. You have to worry about the educational opportunities for your child. Does the school have the resources to support your child? And social isolation because of the child's condition. This is, I think, particularly problematic nowadays with the global pandemic. Everyone is trying to be safe, but people who are immune suppressed are at higher risk, and they're obviously isolating more than those who have normal immune systems. Next slide. The family also has to adjust because of diseases changing course. And previous presentations has talked about, how siblings react and how to deal with, their concerns. Stress among the caregivers. Both parents undergo a lot of stress trying to take care of the child. They'll often have guilt about this, wondering whether if there was something that they have done or they could have taken their child to the doctor earlier, if things could have been changed. And how do you care for the child when family caregivers can no longer provide care? This could either be when the child is older, or if things have progressed so much that they need more round-the-clock nursing care. Next slide. So what happens when you first have, when you're first faced with a chronic illness? A lot of times the first reactions are shock and denial. And we often see this in patients with biliary atresia when, it's often a very young child in the first 4 to 5 weeks of life. And we have to tell them that their baby may have a disease that requires surgery and then may require a liver transplant down the road. They may have a period of mourning for their normal child that they lost. They'll often have guilt and blame. They may go shopping for a better diagnosis. They don't want to believe that they have this. And this can delay care. Sometimes it could be a good thing if they go somewhere with more experience, but oftentimes it can delay care. And then they usually gradually adjust to the diagnosis. And this is where I think we as providers have to provide a lot of support to the families to help them adjust and understand that each family will get to this part in their own time. Next slide. So families and parents especially often worry a lot about education. Their child has to have the appropriate education. So patients who are in the hospital a lot will miss school. They'll oftentimes be behind a grade. You have to have the access to early learning opportunities, physical accessibility of facilities. If their child has some kind of disability, they worry about acceptance of the child by school personnel and classmates. The schools are often very concerned about a child with any chronic illness, and especially with one that is rare. They don't understand it, and they may not treat the child equally. You have to decide about inclusive versus segregated classes. Sometimes Segregated classes can be safer, but generally we want them to be as inclusive as possible so they can have as normal an education as possible. The availability and quality of homebound teaching for when it's appropriate, and the flexibility of teachers and administrators is very important to accommodate the needs of the patient with chronic illness. Next slide. So how can we help the patient? So we have to identify outcomes and help them plan. You have to give the child some goals so that they can work towards them. Teach them how to perform some self-care tasks. I think the previous presenter was talking about, how they remember how to take their medication. So those are some of the things that you can talk about and develop and give praise towards so that they continue to do those. You have to decrease their anxiety level. A lot of patients and parents in particular are very anxious about giving the medications, which is I think appropriate. But you have to try to let them know that sometimes it's okay if it's 10 minutes late, 15 minutes late. It's not going to be that big a deal, and help them to experience more social interaction. So right after a transplant, we tell the families to be very, very careful because they're on a lot of immune suppression, but we do have to allow them to go and experience kind of normal things, go out in the community, and not to keep their child in a bubble. Next slide. And we also have to help the family. We have to encourage them to increase social interaction when it's safe, help them to decrease feelings of grief and anger and guilt, help them to adjust to living with a chronically ill child. I think one way to do this is to introduce them to others that have children like this, and to show them how they're living full lives. You have to teach them about caring for chronically ill or disabled children. And I think that's where our child life and social work really, really help us to try to teach tips and tricks about what to do. Help the caregivers accept the condition, that oftentimes people feel like a transplant is going to cure the disease, and what we like to tell them is it's trading one disease process for another, and it's something that can be managed, but it still needs to be taken care of. And to help them in any home care needs they need, whether it's nursing assistance or help with kind of like school IEP type of things. Next slide. Now, there's been increasing research about social determinants. So what are these? They're things like social exclusion, food insecurity, health services, gender, disability, and housing. These are not things that we sort of were taught that affect the medical condition, but all of these play a big role in the family's ability to cope and in the child's ability to recover from a transplant. For example, if we do not ask about food insecurity and the child's not gaining weight, we may think that the disease is progressing when actually it's just it's a matter of increasing food. Things like the social safety net, if a caregiver is becoming very stressed and they have no one to go to or no one to help them relieve that stress, then that will negatively affect the child as well. And we have to take into account disabilities. You can't ask a child to kind of walk around or be more active, if they have a disability. And then of course, housing is very important there. We do have patients who do have either inadequate housing or, housing that may not be safe for them if they have a chronic illness, and we have to take that into account when taking care of these patients. Next slide. So there's many types of support. There's, formal supports and informal supports. I think, informal supports are things that we can do just by, talking to the families, listening to them, involving child life and social workers. Formal supports could include things like government programs and other things like like this group that may help families cope and deal with a child with chronic illness. Next slide. So one other thing that we can talk about is trying to find some meaning in life. A lot of times when you have a chronic disease, it's, you know, it really sucks. And you have to, you know, try to encourage the families and encourage the patient if they're older to try to find, some meaning beyond the fact that they've had a transplant. So chronic diseases, you know, often will challenge people's beliefs and hopes, and finding a meaning is an important process of having hope. And high levels of life meaning have been linked to better health-related quality of life. So, you know, we feel like the more people can move towards living a normal life, they will have a higher quality of life and have better overall outcomes. Next slide. So, you know, I'd like to say that, you know, it's very important to keep calm and hope and dream. I think the field of transplantation has come a very, very long way from the very first transplant, and even in the last 30 years, I think our survival rates have been very, very good, and we have to move towards, you know, beyond survival and improving things like reducing immune suppression, reducing the burden on caregivers, reducing the burden of medication, and looking at, you know, what little sort of tips and tweaks we can do to bring kids from just, you know, living with a chronic illness to living their whole lives and thinking about their transplant sort of as a secondary thought. And then, you know, it's also very important to practice self-care. Patients and caregivers need to acknowledge that they may need, you know, time for themselves. They need to be able to, you know, the patients need to be able to, you know, do some of these things on their own. They need to know how to take their medications, remember how to take their medications. It's going to be a part of their, you know, daily lives, and they have to sort of incorporate it into their daily routines so that it becomes a habit. Next slide. I think that was it. So I just want to say, you know, there are a lot of things to talk about on this topic. Some of them are, you know, related to how a provider takes care of a child, and some of it goes towards how families take care of their children. I think it's very important to have, you know, to think of it as a team effort, because, you know, we cannot do all the things. We don't understand everything that's going on at home. It's important for us to partner with the families and hear their thoughts and hear their concerns, and try to tailor how we approach each of these children and families to hopefully find the optimal outcomes for everyone. Thank you so much.
Thank you, Dr. Mohammed. Thank you very much. Our next speaker, and then we'll take questions again as we have been doing after our next speaker for both Dr. Mohammed and our next speaker, who is Sierra Nagar. And Sierra is a licensed dietitian and nutritionist at the Duke University Hospital. She's their clinical pediatric dietitian who's trained in nutrition, dietetics, and biochemistry. And she's going to speak on a critical topic. Dr. Mohammed alluded to the importance of understanding this, and that is nutrition in children with liver disease or after transplantation. Sierra, looking forward to your presentation.
Thank you so much. I feel really grateful to be here to speak on this topic. So yes, I will be talking about nutrition in liver disease and transplant. Next slide. So a few of the objectives that I hope to really instill today are just taking a look at what normal nutrition looks like in children that are in a healthy state, and then versus nutrition needs of those children with liver disease. We'll look at causes of malnutrition and why that is a big important factor, discuss types of nutrition support that may be necessary, and then lastly, review food safety guidelines for post-transplant. Next slide. So before getting into specifics about nutrition and liver disease, I just wanted to take a quick moment to talk about nutrition in general and why it is important. Next slide. So one of the biggest things that we think about when we think of children and nutrition is that we need it for growth. So unlike adults who just require adequate nutrition to make sure that they maintain normal body function, children require adequate nutrition for that purpose, as well as making sure that they are developing appropriately and having normal growth. Because without proper nutrition, we can see issues with stunting or significant weight loss, as well as developmental issues. So, for instance, if we're not giving enough calcium, we can see weak bones, or if we're not giving enough essential fatty acids, we can see some issues with brain development. And then lastly, providing healthy nutrition habits early on in life can help prevent potential health issues in the future, such as obesity and diabetes, just to name a few. Next slide, please. So I know this slide is a little bit overwhelming with all of the numbers, but I just wanted to kind of show from a dietitian perspective how we're estimating children's needs. So looking at calories, protein, and fluid. And although these are a great place to start and they are averages, we know that it's not a one size fits all for every child. So really making sure that we're monitoring growth all of the time, and then taking into account if we need to add a little bit more nutrition or a little bit less, just to make sure that we continue appropriate growth throughout the life. Next slide, please. Okay, so now we'll get into nutrition and liver disease. Next slide. So one of the biggest concerns that we have from a dietitian perspective is the increased risk these children have for malnutrition. And malnutrition can mean either they're undernourished, it can also mean that they're overnourished. For this talk, we'll focus on children who are undernourished, as that is what is most common in this population. And so while malnutrition is concerning as a whole in general, it becomes a little bit more concerning when maybe liver disease has progressed to a point where they're going to require a transplant, just because studies have shown that poor growth prior to transplant or being malnourished leads to poorer outcomes after transplant. Like I also mentioned earlier, they need more calories, more protein than adults to make sure that they're growing appropriately. And specifically in this population, they have increased needs on top of that as well. And then lastly, kind of looking at more of a post-transplant issue, refeeding syndrome can be a big concern. If you think of going into transplant with a poor nutrition status and then coming out of transplant, and we're really trying to push calories and nutrition to try and catch up, we can get in a dangerous place of those electrolyte shifts that could potentially be fatal if not taken care of. And so really trying to optimize nutrition prior to transplant is our biggest concern. Next slide, please. So assessing for malnutrition in this population can be quite tricky. Most of the time, weight gain is not quite accurate, and that might be because these children accumulate a lot of fluid. They have those large bellies, and so even if we see weight go up, we are initially thinking it's probably fluid related, and they likely still need more calories. And so a way that we can double check this, so to say, is to take what's called a mid-upper arm circumference. And that is a little bit more accurate just because we want to look at lean body and fat mass, and the area of the upper arm is less sensitive to fluid shifts. And so I just kind of wanted to give an example here. This picture shows a little boy or girl getting their mid-upper arm taken. And then this growth chart behind, I wanted to give an example. This patient that I saw initially was receiving a significant amount of calories, 200 calories per kilo. And just to put that into perspective, a child of the same age without liver disease would estimate to need about 80 to 100 calories per kilo. So almost double what a normal child would need. And they were drinking a significant amount of formula, up to 56 ounces per day. And although we see the weight kind of trending up right there, it was mostly fluid related. And we double checked that with taking a mid-upper arm. And we saw that his Z-score was very low. So if we have a Z-score of -3 or greater, that indicates severe malnutrition. So despite pushing calories orally and via tube feeds, ultimately we had to start this patient on TPN, and I will talk about that a little bit more later. Next slide, please. And so we've been talking about malnutrition and how patients with liver disease are at a higher risk for this, but why are they at higher risk? And so one reason is because they have increased metabolic activity that requires higher energy needs. Again, like I showed in that last slide, they could need up to 2 times what a normal child needs. But it can be really difficult to get them those increased needs because they may have a poor appetite and intake. This could be due to reduced gastric capacity. Either they have a lot of fluid accumulation or they have an enlarged organ, which leads to them feeling full earlier, so not being able to take in as many calories. They may also have oral aversion. We see this a lot in kids who require tube feeds, who have gotten nutrition from other aspects aside from eating. And so that can put them at a developmental delay as well for kind of keeping up with what they're taking orally. And sometimes these kids are on formulas that don't taste the best. And so if they don't like the taste, then they have a decreased desire to eat as well. And then lastly, some of these kids may be suffering with nausea and vomiting, and nobody likes to eat when you feel like that. So that's an issue. And then lastly, these children have trouble with absorbing and digesting and absorbing foods properly. And also they have increased nutrient loss from, again, vomiting, having increased stool output. And so not being able to absorb all of these calories that we're giving them kind of is like a vicious cycle of what leads to malnutrition. Next slide, please. One more. So kind of going off being unable to utilize nutrients properly, I wanted to look at macronutrients. And so this consists of the carbohydrates, protein, and fat that we have in our diets. And so looking at carbohydrates, some of these kids are at risk for low blood sugars, and that's just because glycogen storage is depleted with liver disease. And so sometimes they may require constant nutrition to make sure that their blood sugars aren't dropping. And doctors may have you check your child's blood sugar at home as well, just to make sure we know we're giving them adequate nutrition. Protein breakdown is also increased, which can lead to toxic waste buildup, such as ammonia, and then which can lead to encephalopathy. And fat is really hard to digest in these patients. This is probably the biggest macronutrient concern. And so a lot of the time we will require formulas that are a little bit broken down and have higher MCT content, like this formula on the slide here. Progestamil is a very common one that we use. MCT is a lot easier to digest and absorb than other fats. And so that's a good way to try and give a little bit more calories more easily. However, they don't have those essential fatty acids that we require for development and growth. And so we worry about essential fatty acid deficiency, which is another cause of poor growth. And then if we don't have those essential fatty acids, thinking back to the issue with poor brain development. Next slide, please. Okay. And it's it's a little bit more difficult to see the impact micronutrient deficiencies have on our bodies compared to macronutrient deficiencies. If you think about if you're not getting enough carbs and protein and fat, you see weight loss. But if you're not taking in enough vitamins, it's really hard to see an immediate impact. But they are very important. And while all vitamins are important, in this population specifically, we're going to look at A, D, E, and K. They're known as fat-soluble vitamins. And so because children have a harder time absorbing fat, they have a harder time absorbing these nutrients as well. And I won't go through all of the details here, but making sure that we are promoting foods that have high sources of these or high levels of these vitamins is important, but oftentimes they will require additional help through supplementation with vitamins like Aquadex or DECA, just to make sure that we're really packing in those nutrients to make sure that we can maintain those levels and avoid any adverse effects from deficiencies. Next slide, please. Okay, so sort of like I had alluded to before, some of these children will not be able to maintain proper growth on oral nutrition alone. And so very often they require some sort of nutrition support. And during the pre-transplant evaluation period, I always like to kind of give parents a heads up just so that they're not kind of blindsided by this if it is needed, but it's not uncommon for children to require tube feeds to help them grow. And I like to also tell families it's not permanent. It's just something to help get us in a better nutrition state. That way we're in a better state after transplant as well. Typically they'll have what's called an NG tube, and it just goes right in your nose and down to your stomach. And that is the preferred route just because it's easy to remove, it's less permanent. And then type of formula is also very important. I had shown progesterone before, and that's one that, again, we typically use. Just because we're giving tube feeds doesn't mean that they can absorb other formulas better. So really making sure that we're looking into that formula that's going to help them grow the best. And then looking at bolus versus cycled versus continuous feeds. We like to try and do bolus feeds because it's more similar to like meal times at home. And so it makes that quality of life better. And sometimes that will be paired with tube feeds cycled overnight. That way during the day, they can be off of tube feeds. But oftentimes to be able to give the proper nutrition that we need and to, again, ensure that blood sugars aren't dropping, we often require tube feeds to be given continuously. And then if we continue to see poor growth on enteral nutrition and oral intake, a child may require TPN. This is our last option just because it has a higher increase or an increased risk of infection just because you have a central line. But children do grow very well on TPN. And so they won't be on it for too long, just to, again, optimize nutrition to get them through transplant. Next slide, please. Okay, so once we get through transplant, I wanted to talk about what looks different nutritionally. Next slide, please. And I apologize, this image is a little bit blurry, but I did like how it showed the difference between nutrition needs before transplant and then after transplant. So kind of like we've already discussed before, they need a greater amount of calories and protein to support normal growth. And afterwards, because their liver is functioning properly, they don't need quite as many calories. But we don't want to just immediately drop to what the average would be. We want to go slowly to make sure that we're still maintaining proper growth. And we don't need to push as many calories, kind of like we had before. And so although the child has gone through liver transplant, there is still a possibility to damage this new organ. And so kind of like Dr. Mavis talked about earlier, that can include fat buildup. And so making sure that we're educating on an overall healthy diet, which includes multiple servings of fruits and vegetables, lean proteins, whole grains, and then limiting those sugary foods and beverages, and increasing physical activity if possible to make sure that we are preserving the health of our new organ and then just overall health in general. Next slide, please. And the biggest thing that I talk with parents about prior or post-transplant prior to going home is food safety. Next slide, please. And so this is just a fun little slide with different images to kind of help you remember some of those important things. So first of all, making sure that we're not eating foods that look moldy or are expired, or maybe at the grocery store, the cans are dented, anything like that. We want to avoid that at all costs. Also wanting to make sure that when we're preparing foods that raw meats and then vegetables or fruits or fresh foods are prepared separately. That way we avoid cross-contamination with raw meats. Making sure that we're cooking foods to a proper temperature is important, and then chilling them so that bacteria don't grow. Washing our hands and just having proper hygiene. Making sure that milks and cheeses and fruit juices as well are pasteurized. It's an extra process that they go through to make sure all of the bacteria are killed off. Thinking about things such as buffets, or if you're going to a party and people are able to serve themselves, just being extra cautious in that scenario because we don't know who has touched what and if they have practiced proper hygiene. Making sure that our water sources are clean. And then lastly, just really telling patients, the only one thing that you can't have is grapefruit, and they're usually very on top of that. Next slide, please. And so this is sort of the same concept, just written out. So things to avoid, and then just some important tips to remember. Next slide, please. And then these are really great resources that I will provide families with. And so I wanted to kind of link them here as well. This one on the left, the food safety handout, kind of goes through everything we briefly touched on. And I like that families can have something physical to take home with them that they can reference once they're out of the hospital if they forgot to ask a question. And then this Food Keeper app is really helpful too. You can look at, how long can I keep a food? What temperature should I keep it at? And so just, again, being extra cautious that the foods that we're eating are not contaminated. Next slide. And that is it. Thank you so much.
Thank you so much, Sierra. That was great. Well, we have some questions coming in. How about basic questions on hydration? What do you tell your patients after surgery in terms of like health, easy to remember guidelines for staying hydrated, and that aspect of their intake? Thank you.
Oh, forgot to unmute myself. Yeah, hydration is extremely important. A lot of times these kids will be on IV fluids first, and then as they can start to take more after recovering from surgery, we really push them to take in as much as possible. And so sometimes children have a hard time drinking just water itself. And so we can think about different ways to make that more exciting, maybe adding in some sugar-free packets to flavor it, to make it more enticing. And also we can look at different formulas like Pediatric or Boost Kid Essentials. They also have some free water in there. And those are definitely more appetizing and fun than water itself, but it does provide free water in there to help maintain hydration.
Thank you. A lot of families also wonder about kind of catch-up growth and what they should expect in terms of, they've been ill for 1 or more years, and what do you tell them about where they should expect to be, and like how fast they should expect to try to get there back to a healthier weight after a transplant?
Yeah. just in my experience, I definitely have seen children after transplant, their growth picks up pretty quickly. And as far as like where they should be, if we look at a growth chart, obviously that 50% is the average. But I try to encourage parents if I show them the growth chart, and I just want to make sure that, you know, their child is continuing to trend along their own line, so to speak, for weight and height. And as long as that's happening, then we know we're in a good state. We don't have to try and be right at the average.
Thank you very much. There was a question about food allergies before. Do you counsel families about that aspect of care, and what's been your experience with food allergies after transplant?
Yeah, I wouldn't say that it's super common at all that I have seen, at least. But obviously just encouraging families, if they notice an adverse reaction to some foods, to avoid it. And especially in these babies who are transplanted so early and then afterwards are just being introduced to these solid foods, just making sure we're introducing like one puree at a time, waiting a couple days, and then introducing another one. That way, if there is an adverse reaction, we can really know which food it was from.
Question for Dr. Mohammed. Dr. Mohammed, in terms of support for families going through chronic liver disease, have there been, there's a lot of disease-specific support groups that are available. In your experience, has there been an organization that stands out, or a support group that stands out to kind of go over those aspects that you alluded to in your presentation about developing, you know, a routine and moving through the different stages of their disease, or have you encouraged mostly for the families and patients to connect with their care team primarily?
So yeah, I think the issue with liver disease is it's so variable that you know, one person's experience may not be helpful to others, but in general, you know, for the patients who had a transplant, I mean, internally at Lurie Children's, we do have a program called ParentWise and one called PeerWise, where we have people who had a transplant who could talk to the kids as peers, and then ParentWise, where they talk to the parents. So that's been something that's been going on for a long time. But I think in the last, you know, 5 or 10 years, most of the larger organizations have also incorporated sort of a family voice. So for transplants in particular, I refer them to Split. And Split has which is a Society of Pediatric Liver Transplantation. And they do have family members some of whom I think are on the call too, who can be a resource for people who are going through transplantation. I think, you know, just speaking about Alagille as well, I think the Alagille Alliance also does a very good job of doing this. So I think previously you used to have to connect with somebody locally to be able to, you know, talk to them and possibly even meet up with them. But now with you know, with the, you know, internet and email and things like that, I think it's easier to connect with people from across the country. For kids, I feel like it's great if they could meet somebody their own age who's gone through the same things, because they'll probably ask them things that they will not ask us, or think that, you know, we won't have the answer to, or think that we, you know, may be silly. So I think the more you show that it's not, maybe it's, you know, it is rare, but maybe not as rare as they think, because a lot of families have never met anybody else with Alagille or with biliary atresia. And so, so I think that it's helpful, you know, in that way.
Thanks.
And George, I want to ask you actually a question. This food allergy question. Do you tell families about? So I'll say I do not talk about allergic reactions or skin conditions to somebody who's post-transplant, unless they have them or they develop them. But I don't bring it up beforehand.
I think that's our practice too, as well, that we We may allude to it very briefly in some pre-transplant materials, very, very briefly, but we only address it in terms of someone who may develop some symptoms. And I think in the years that I've been caring for the patients, there has been one patient that we've switched off tacrolimus because of a significant, what appeared to be a significant allergic reaction that would manifest as enteritis, and otherwise it's been rare in my experience. But I think it's similar to what you do. We address it as it comes up.
Yeah, and yeah, we've seen some food allergies with tacrolimus as well, and have had to switch people off, or at least try to switch them off and see if it improves, and use another agent.
A couple of one question from a participant about medication adherence in older patients, potentially adolescents. Maybe I'll have Dr. Mohammed address that. Any experience or recommendations about improving or maintaining adherence and transplant immunosuppression adherence in that population?
Yeah, I think, first I'd say is good luck. I mean, older kids are, just like with everything, they want to, they want to sort of assert their own authority. Sometimes they'll want to sort of challenge things. Some of the things they took for granted when they were younger, they want to start asking, why do I have to do this, or why do I have to do that? And so I think going on with the theme of this whole conference is, involving them as developmentally appropriate as possible, to let them know, why they're taking it. It's not something that, you're forcing on them, but it's something that they really need to kind of take, and have them take the responsibility, as early as you think is appropriate as well. I think one of the point of one of the earlier panelists was, putting the medication on the night dresser, or, we've told some people to put it near their toothbrush, because hopefully everybody's brushing their teeth at night. So they'll remember to take it at that time. So I think it's very hard, and we know that the adolescent age group is a time when a lot of, it's a time of great risk. A lot of patients do lose their grafts, and it's a time when, parents are thinking that their children are able to assert some independence. But I think it's still important for the caregivers to watch what's going on, because, children are still children, and will forget and may not take their medications. And it's very important for them to continue the same routine. So I think, involving them early on, making sure that they understand exactly why, not that this is just, some pill, but it's something that they really, really do need, and it's important for their health, and it'll help keep them out of the hospital and help them live a, normal life.
Thank you very much. I'd like to just to transition for the last few minutes here into asking all of our panelists, who are still here from the morning, if you could turn your cameras on, as well as Dr. Mohammed and Sierra and our family members. I think I'm just going to ask you one question, either in your field or in your experience as a patient or family. What's one innovation that you think would be most important for you or for your family or for your patients? One innovation that is either around the corner, or maybe just that you've dreamt that this would be the case. So how about if I start with, let me put Sierra on the spot. What's an innovation that a nutritionist, dietitian expert would dream would really be impactful for children?
I would love to get the ability to do indirect telemetry in our hospital, so that we don't have to estimate needs anymore, and we could be way off, way high or way low, but we would really get to be very specific with each patient and tailor the needs a lot easier. And
how complicated is that to happen right now?
I think it's more of an expense issue right now.
Okay.
So we don't have that availability right now, but I hope one day we would be able to get it.
Excellent. Thank you. How about a parent perspective? One innovation that you want the Community Liver Alliance to work on in the next 5 years. How about that?
Oh,
Or
wow.
10 years? Anything come to mind?
It would be great if she could go off, the Prograph. That would be fantastic. Liver wise, we're pretty good. The technology was there when we needed it. For her RP, like if the stem cell research could correct that so that she could see with that part of Alagille's, that would be fantastic. I think just educating people more, making resources available for parents.
Yeah, thank you. I'll go to Dr. Mavis. What would, in your experience, your dream scenario, what innovation do you anticipate, or do you want the community to work on?
I would love some more treatment for biliary atresia that doesn't just require everyone needing a transplant at some point in their life, or even some gene therapies for some of the metabolic diseases. Transplant's great. We have great outcomes. We've made a lot of strides in transplant, but it's still a chronic disease for life with, at this point, for most patients requiring medications for life. Hopefully that will change, as Carla was saying and Dr. Mohammed talked about, but trying to find some more treatments for these diseases that are not transplant related.
Thank you. Brittany, what about you in your work realm? What's your dream innovation? And I think you're still on mute, but.
Thank you. Sorry. It was touched on a little bit earlier about adherence and adolescence. And that's something that I think any provider can say is always a struggle, as Said kind of pointed to. So for me, if there was some sort of, you can't send a text, you can't get on Instagram, you can't whatever until you've taken your medication, maybe that'd be like a really strong way to ensure people were a little bit more compliant with their medication. That would be maybe a technology thing that would be interesting in the future. But I think I'm feeling really grateful that in this day and time, there are so many reminder apps and really great ways like telehealth to get a hold of people. So I think all that has been really helpful.
Dr. Mohammed, how about you?
It's a hard question to answer, because I think there's a lot of things that would be nice. I think from a transplant perspective, a better way to gauge how much immune suppression somebody needs, rather than the sort of the trial and error of a level, doing labs, checking levels and checking doing biopsies. So maybe sort of a non-invasive way to measure how well your liver will, or so how well your body will accept the liver or not. And then I think there's a technology that's it's out there, and that's but hasn't really been used so much, is some of these normothermic perfusion technologies, where they get a graft that may not be perfect and sort of put it in an incubator for a day or two and see whether it works better or not, and then use that. I think that can really help increase the donor organ pool, and that's where a lot of people are still dying on the wait list, and that may help with that aspect.
Thank you very much. I think for before Dr. Mohammed asked me for my innovation, I'll go ahead and not excuse myself. I think two things stand out. One, I think you alluded to, and that is that it is exciting that we have the technology to save children with liver disease, but yet children still do die on the wait list. And so I think my short term, and I hope within 5 years, that we can, at first in the United States, eliminate anyone dying on the wait list who's waiting for a pediatric organ, any child waiting for an organ transplant. And then I think Dr. Mohammed alluded to just the opportunity to personalize approaches for medication until something eliminates transplant. We want to manage the transplant better. And so I agree with him on that idea of personalizing and then helping, as Brittany said, for the patients to take their medication and keep that graft healthy for as long as possible. Well, I think we've just given the Community Liver Alliance their marching orders for 5 or 6 projects to work on. It's something that I'm sure they're excited to handle. I know we have we still have that survey to do, but I'm going to turn it back over to Deanne Gerard to close out the symposium. And I really thank the presenters for their engagement today and all of the audience. And thank you for the opportunity to be here together with all of you. Let me turn it back over to Dee.
Afternoon, everyone. First, I'd like to say thank you to our course directors, presenters, and our partners at Alexion and FedEx for supporting this pediatric conference. And I also would like to say that the Community Liver Alliance is up for the challenge of doing all those things. In the next couple of weeks, you all will receive a gift card to have lunch at your leisure as a thank you for joining us. And we are going to be sending out that survey to you via email that we're asking you to complete. Until then, I would like to say from the Community Liver Alliance, have an extraordinary holiday season and a very, very healthy new year. Thank you.